here's what we're proposed to do in this session. First of all, I invite Catherine to just kick us off, and then as soon as she's done that, I will get going. Catherine, please.
Hello, everybody, and happy Friday. I don't know what it's like where you are, but it is cold as here in Geneva. So we all have our warm cups of tea, and we're looking forward to this warming up session. It always is lovely to be with friends at the end of the week. I want to mention to everybody that we are recording this. You will already have seen that pop up on your Zoom. And we usually post these YouTubes on David's and 4SD's website. So if there's anything that comes up or anything that you say that you don't want included, I'll make sure my email address and Mahika's email addresses are in the chat. You can just let us know and we'll edit the video. We will be joined by Live Illustrations' Chris Shipman, but he at the moment is on a bus that is standing still somewhere in London. So he will get to us as soon as he can. And we'll welcome him when we see him. In the meantime, there's been a lot going on with COVID, Omicron, numbers, vaccines, everything else. And we look to David to help us make sense of it all. Thank you, David.
Thank you very much. Andre Hoffman, how do you do? Marianne Hasselgrave, thank you for joining. Annie Feltham, hello to you. And I think Rebecca has just come on, Rebecca Cantor. Very, very good. If I can get the screen share to work, then I will try to show you the latest global epidemiological figures. I'm having such problems with sharing screen shares, and but I think I've got it, so we'll come to that in a minute. Let me just give you my quick take on what is happening with the pandemic in Western Europe and then in the wider world. Now, I think that the most important thing that I need to start with, and this is where I usually start, is that when COVID happens, it's in a surge, quite often a dramatic surge with quite rapid doubling times. And when that surge occurs, transmission tends to be in quite tight geographical areas. This is because the majority of transmission is by droplets. It's not by aerosol. And if you've got droplet transmission, most of the infection happens when people are within 2 meters of somebody who is expelling the virus. And just think about that. You know, measles and flu are both aerosol. They're both transmitted in gusts of air, and you can very quickly get the virus spreading right through a population, a bit like wildfire. But this current coronavirus and other coronaviruses tend to be more droplet borne, and that means that mostly the incidence is quite tight in terms of geographical location. Now, of course, in every bit of life, there's always exceptions, and occasionally we do get instances of aerosol transmission. You get a whole factory affected, or you might get a whole military barracks affected, or a whole cruise liner affected, and then it's moved from being droplet borne to being aerosol. And I like to keep reminding people about it being primarily droplet, because it does explain the rather peculiar characteristics of outbreaks that occur. They tend to be quite specific in terms of their physical location. What this also means is that when you look at figures of incidents in a particular population, even if the numbers are going down, what's actually happening is there are probably a number of very small outbreaks occurring and some big ones, and that the overall aggregated incidence figures may present a downward trend, but you've still got explosions occurring inside particular areas in your country where there's a lot of cases. And do keep remembering that, because it just reminds us that not everywhere is on the same position as the national or regional epidemic curve that you're looking at. Now, because this occurs in surges, I've always said that the primary approach to dealing with disease has to be for people to be able to protect themselves from infection. And so there is a huge amount of importance that I give, and I think everybody in the WHO gives, to the need for people to have the information they need to know what are the activities that we believe can reduce incidence. And we strongly believe in the value of well-fitting face masks, surgical masks or FP2, and we believe that these masks should be worn, particularly where people are in confined locations, especially indoors. We also believe that you need to focus on ventilation in order to increase the movement of air. We believe that physical distancing remains really essential, and we believe that hygiene, i.e. cough hygiene and hand hygiene, is absolutely critical. We want to see people who we know to be at high risk, older people, people with some kind of immune challenge, or people who've got concomitant illness like diabetes or cardiovascular disease. We want them to be protected. We want health workers to be protected. What I'm telling you are the basic principles of dealing with a droplet-borne infectious disease. And if you've got a virus circulating in your community, even if it's declining in overall amount, you must respect this. You must follow the principles. I'm talking in terms of must here because I'm giving you my personal take on it, which is entirely in line with the position taken by the WHO. And I wanted to start with this because there are some places right now where there seems to be a deliberate attempt to reduce the possibilities for personal prevention, to reduce the role of the individual in actually trying to act to reduce transmission, to encourage people to just let the virus go. And honestly, in WHO, there is nobody who believes that this is a viable strategy. In fact, we think that it's quite dangerous. This virus is still new. We've known about it for 2 years. We're learning about it all the time. We still don't fully understand the determinants of a surge. We think that it's to do with percentage of people who are vulnerable. We think it's to do with the viral load that they encounter, but we don't know the full details. It's super hard to explain the epidemiology. And Omicron, the new variant that's moving so fast, I first really found out about this from South African colleagues in mid-December. So that means it's only just over a month since I've had any knowledge of it. And our colleagues all over the world are still really trying to understand, not just about Omicron in the longer term, but even Omicron in different communities with different levels of immunity and so on. And we absolutely have no information about the long-term implications of Omicron. I asked Claire Rayner 2 weeks ago, does Omicron cause long COVID? And she said, well, there's still work being done. I hope, Claire, if you stay on right through, will be able to give us some more views, and perhaps Paul will be able to do the same. Because in the absence of knowledge about the long-term impact of these viruses, it is really important that everybody everywhere continues to treat this as a dangerous virus and not to think of it, whether we're talking about the original Wuhan strain or the variants that came on subsequently up to Delta or the new variant Omicron. Nobody should use the word mild to describe this. In fact, WHO in the last week has been at pains to say that we can talk about a lower lethality, a lower severity, but we should not use the word mild. Now, we've consistently said that vaccination is incredibly powerful as a tool to de-link severe illness and death. And that if people are vaccinated, this gives them a most amazing immunological shield, combination of humoral immunity and cell-mediated immunity. And it's quite important that that shielding is done in a very thoughtful and effective way. Those people who are most at risk should be the priority from being offered shielding vaccines. Now, most people are saying, well, for the vaccines we have right now, it seems that probably 3 doses are what you need to get your antibody and cell-mediated immunity responses properly primed. And that does seem to make an awful lot of sense. Some are telling me that a combination of vaccines seems to be rather useful at the moment. One specialist said to me last week that the combination of 2 times AstraZeneca and 1 times mRNA gives a pretty good all-rounded prevention. Well, that's the kind of thing we hear from lots of places, lots of different bits of evidence starting to emerge, but in no way can we say that these sorts of findings, often appearing in the press, they cannot be given particular significance when it comes to strategy until we've got a lot of instances of data. Right now, an awful lot of vaccination strategy is being made based on data that would not normally be used for the assessment of vaccine utility. And so I want to ask everybody to be cautious when you read about people being given extra boosters in certain countries, or people being offered particular combinations and they are better than other combinations. Right now, the basic feeling is that if you've had 3 immunizations with the immunizations on the WHO external use, emergency use listing, you've got about the best protection that we think is available. There is not good information on how quickly that capacity to be protected declines in the interval, either after vaccination or after infection, or a combination of the two. And so any kind of prescription on the right kind of vaccine dosage and the possible place of extra boosters up to 4 or even 5, we cannot say, at least WHO is not saying. And I have to tell you this because today I was once again asked about the virtues of extra boosters in media, and it's something where right now WHO is not advocating constant boostering. I think that I'd like to stress that we still have a massive problem of vaccines being inappropriately distributed, and it is really essential to get vaccination more equitably available. That means both sufficient supplies being available for COVAX and other mechanisms, but it also means a concerted program of support to poorer nations so that they can build up the capacity to vaccinate. And it's particularly challenging for them dealing with the mRNA vaccines, which have to be kept super cold. Yet at the same time, this is what a lot of them wish to access. And so the urgency right now is for a global COVID-19 response program that combines support for vaccination with access to diagnostics, access to treatments, access to the essentials for medical care, plus prioritization of the needs of health workers everywhere. Without a global program that takes the issue seriously and seeks to address inequities, there is no way that we can consider that the response to this pandemic is anything other than totally suboptimal. And I have been increasing, together with others, my call for a global response program, especially because of the confusion right now around what are the best ways in which societies can cope with the virus, and especially with Omicron. Now, one of the other consequences of a world where there is not a systematic global approach to response is a sense by many people in many communities are going down 2 different directions. One is that the individual doesn't matter, and that all that's really happening in regard to this pandemic is competition between leaders of different governments trying to show that they are better than others in being able to deal with it, often actually adapting data to suit particular strategic options, or a sense that actually people everywhere don't really matter, but particularly in poor countries. And what's really happening in this pandemic is that rich people in rich nations are looking after themselves and poorer people are being left to fend for themselves. Either way, the sense that political leaders are in competition, or the sense that it is all being weighted in favour of wealthy people from wealthy nations, it's not a good situation. And in our regular exchanges with leaders from around the world, we have seen a hardening of attitudes in early 2022 and the appearance of more and more fractures in communities, and the possibility that this leads certainly to an unwillingness to participate in public health response measures, and actually civil unrest is made more likely. Just this last week, the Edelman Company, one of the most well-established public relations companies in the United States, produced the latest version of their annual Trust Barometer. This is a public relations study, which means that they take samples of people from around the world and they go to these samples with a very well-designed, well-executed, formal questionnaire in which they ask a series of carefully designed questions to try to ascertain which sources people trust on what issues, and they've been doing it in special detail in the last 2 years on the pandemic. And the result that was reported on during this week on Tuesday the 18th is that trust in authorities is at an all-time low, and that trust in governments and the mainstream media is particularly low. They've done their study in 33 different countries, and so if you look at it, it's available on the Edelman website. If you look at it, you can see that there's quite a differential in trust, and I'm not going to go into that in detail. But what is particularly coming out is that there is actually a narrowing of the circles of trust that most people are prepared to admit that they have. They are tending to trust people up close to them, family, friends, long-term medical advisors and so on. They're also trusting local businesses because they believe they're more straightforward, and they're trusting some CEOs and internal company communications. They are mistrusting social media and so on. I mean, where does this lead us? It leads us into a major, major difficulty because, as I've said repeatedly in these briefings and elsewhere, the virus is the problem and people are the solution. That means responding to this pandemic involves taking people alongside authorities and actually working closely with them, something that we found worked very well in responding to Ebola in West Africa in 2014, 2015. But if people, for any reason, feel that they cannot trust those who are asking them to behave in particular ways, they will work in different ways, and this will not be helpful when it comes to dealing with this pandemic. In order to secure trust, there is an absolute need for messages to be communicated in a way that makes sense to people. One of the things that we've been trying to discourage is decision makers who are trying to do delicate trade-offs between different options for dealing with the pandemic. We're discouraging decision makers from making promises that certain things will happen on particular days, 4 weeks ahead, 6 weeks ahead, 8 weeks ahead, or whatever. The reason why we say that's a bad idea is that once a decision maker has made a promise, then shifting, perhaps because the data are different, becomes really difficult. It means that the decision maker is going to lose political capital. So we're saying do not make promises when it comes to COVID. And here are 5 reasons why we think this is important. Firstly, the whole of humanity is threatened by COVID, and so it's really not feasible to assume that you can just deal with a population in one particular geographical location and behave with that population as though they are somehow insulated with what took compared to what happens elsewhere in the world. It is a global issue, a one humanity problem, and dealing with it in individual countries as though they are sealed off from the rest is just not sustainable. Secondly, when you're responding to COVID, respond to the whole person and the whole community. Remember that in any community, it's poorer people in poorer settings who are most likely to be affected badly by the virus and most likely to be affected badly by containment measures. To take a whole person, whole community approach and take equity seriously. It doesn't affect everybody equally. And all too often, prescriptions that are made don't take account of some of the major challenges faced by poorer people who don't have cash reserves, who can't easily work from home, who don't have internet access, who are not able to get easy entry into institutions where they can get care. They are the ones who are suffering the most. Thirdly, I've already said that the virus is new. What do we have to do when something is new, when we don't know much about it? We have to display genuine humility. I don't mean any kind of false humility. I mean the humility that means I don't know, and it's okay me telling you that I don't know because this is a new virus and there are so many things we don't know about it. So maintain genuine humility. Fourth, be honest. Don't make false promises about anything, because you may well have to backtrack on them. You will further undermine people's trust. And the only way you can be considered authentic if you are providing leadership on COVID is by being honest and by making certain that you don't lie. And if you do lie, admit you've lied. But don't go and try and cover it up. And people in leadership positions who are lying around issues to do with COVID cannot possibly hope to maintain the trust of their societies. And finally, be hopeful. Pandemics do come to an end. If we look in history, it sometimes takes many years for them to come to an end, but they don't go on forever. The whole way in which viruses come into humanity, into human populations, is that they evolve, and they evolve over time, and over time they tend to become less severe, and they tend to be part of the viral ecosystem, the biome in which we all are functioning. And we can hope that there will be a point reached where this virus will become like another coronavirus causing common cold, that it will become something that we do manage to live with. We take precautions, we protect the people who are at risk, but we live with it. We live with it in an enlightened and smart way. And so, yes, we can hope for that, but there's no point in pretending that we've reached the end of the pandemic, that we've reached a point where we can all start changing the way we do things before really the science tells us that that's the right thing to do. And if we sort of start saying to people, well, the science says that we can stop all restrictions now, the science says that we don't need to worry about it anymore, what's actually happening? Well, we're actually not telling the truth. We're not doing what is necessary, which is to be driven by the science, and then taking the science into account, you make the trade-offs, but you make the trade-offs in an explicit way so that people understand the trade-off you're making and they understand why you're making it. Now, you've heard me say time and time again that I've never believed that lockdowns are a reasonable strategy and a primary strategy for dealing with this pandemic. Lockdowns have really bad adverse effects on all sorts of people, communities, nations even. We don't favour lockdowns, but we do say there are some times when you've got very high transmission, when you've got big overload in your hospitals, when a whole series of other difficulties are occurring, when you may have to implement quite widespread movement restrictions. But you do that for as short a time as possible. You tell people why you're doing it, and you make absolutely certain that during the time of the movement restriction, you're building up the capacity, particularly for detection, for response, for contact tracing, for isolation, all these other things that are going to become particularly important as the numbers go down. And by the way, Omicron isn't the last variant. There will be others. And although we hope that in the end, the variants that are able to get established will be variants that are less lethal, there will be variants that emerge that have more lethality. They will possibly be localized in when they come out, but it's not going to just be no more variants or no more nasty variants. We're not at that point yet. So, as I complete my remarks, I'd just like to just make one or two comments from around the world that I hope will be helpful, and I want to see if I can actually get things working. This will be messy for a bit. Sorry for this. Here we go. Right, so what I've done here is put up onto my computer screen the global situation as of now, and because I'm trying to be really careful, I don't want to muck around too much, and I've exactly done what I didn't want to do. Sorry for that. Here we go. So, what I wanted to say is that if you remember from previous graphs, this is the one that looks at cases per day right since the pandemic started in early 2020. You virtually can't see the numbers when it was all beginning in Wuhan because the scale has had to be really increased so that we can go up to 3 million cases in a day. Why is that? Because of Omicron. The arrival of this new highly transmissible variant at the end of last year has suddenly led to a huge increase in the number of cases reported to WHO, and Tedros, the Director General, has been very clear this is a huge underestimate. There's a lot more COVID around now. A lot of it is not being diagnosed at all. Some of it is being diagnosed on lateral flow tests quite rapidly. Relatively few cases are diagnosed through PCR. Most of these on this graph are PCR diagnosis, so there's a much, much greater incidence that you can see here, but it has gone really up in the last month. This is not a pandemic near its end. We're also still seeing a large number of people dying whose deaths are attributed to COVID, running at nearly 9,000 per 24 hours. So in the last 24 hours, 3.8 million new confirmed cases, nearly 9,000 new deaths, and they are all over the world, but particularly in the European region and the Americas region of the World Health Organization. I felt that you ought to see that so you can see just how dramatically the epidemiological picture is changing. And then to finish, just a couple of quick comments from around the world. Number one, I wanted to say, just in case you think that suddenly it's all getting great, the hospitals no longer have any people coming into them, we have got data suggesting hospital overload in the Middle East. In the country that I particularly got it from is Algeria. Healthcare systems severely under pressure, hospitals with excess people coming in, a lack of staff, and demand reaching capacity. In Bhutan, data from one district in Bhutan, which has been reporting larger numbers of cases per day, isolation and quarantine centres under increased pressure, hospitals full. That's tiny Himalayan nation, absolutely badly affected. Pakistan got data just during the last few days that the government has all sorts of problems in country with vast numbers of people not well and is having to introduce new restrictions. Colombia, there the hospital cases are high, but there is not absolute overload in intensive care units. Philippines, however, intensive care unit hospitalizations reaching maximum capacity in Manila, and there's been a considerable increase in January compared with December. Kiribati, Pacific Islands, still managing to stay COVID-free, but when its first flight touched down last Friday, with people coming in following the reopening of the country, out of 54 passengers, 36 were diagnosed with COVID on testing on arrival in Kiribati out of the 54 passengers, despite the fact that they were found to be negative on departure. I mean, what does this mean? It means that for many, many countries trying to manage their levels of COVID, it is very difficult. So those are my opening comments. Kath, back to you. If you could just introduce us to what's going on, and I will just check to see who's joined and make a short speaking list.
Certainly. First of all, to say welcome to Chris. I'm glad that you got off the bus eventually. How are you feeling?
Yeah, all good here. Business as usual.
Great.
Thanks.
Great. Do you mind walking us through a little bit of your illustration?
Yeah. Sorry, it started a bit late, but hopefully I've got
No, my gosh, we all understand. Thank you so much.
the top tips for leaders. I sort of adapted it, and I'm sort of going for a sort of zoomed out one this time. So hopefully, very high level summary of everything's been said. So.
No, I like the fact that they're on papers like that. I think that's really useful. And as always, I do love the way you draw COVID. Very grumpy face. So we have a number of comments in the chat, David. I think there was a lot of pick up on the idea of trust and pick up on the idea of the usefulness of data and the importance of data. There's a couple of questions about happenings at WHO and some of the questions about politicians and being able to follow through on the promises that they make. Really looking forward to the conversation part of this. And so thanks, Chris, so much for showing us the illustration. Thanks, everybody, for being here. David, over to you.
Frank Atherton, if you're still here, just Frank and I work together in a number of different things. He is one of the most incredible public health experts that I've had the privilege of working with. He's Chief Medical Officer for Wales. Frank, have I got it right? Over to you.
Yeah, thanks very much, David, and thanks for that tour de force kind of global overview, which is really helpful to all of us, I think. Just a few reflections on what you've been saying. I mean, you're absolutely right. The Omicron wave, took us all by surprise about the speed and ferocity of that surge. We had a doubling time in the UK, and probably people seeing it around the world of 2 to 3 days. So it was extraordinary. I almost got to admire the virus for its ability to infect people. I think we have been, fortunate in a way because, the initial modelling suggested enormous rates of hospitalisation, huge amounts of staff sickness, up to, we had to plan for up to 25% staff sickness, and that didn't transpire. And the reason I think it didn't transpire is partly what you've talked about previously, which is the change in the biology of the virus, being more of an upper respiratory than a deep lung infection. But also, the rollout of vaccination and the booster program. We are in the UK in the fortunate position of being a well-vaccinated population. So our hospital admissions, obviously they went up, people came to harm, but they didn't shoot up in the way we expected. And our ITU admissions, stayed pretty stable. And it's really interesting to look across the water and see what's happening in the US, where vaccination coverage is not as good. And where they're really seeing a surge in hospital activity. So we do appear in the UK now to be coming down the other side of the wave and coming down much quicker than I expected. We always have this lag time, don't we, between community transmission and hospital activity and then ITU activity and then sadly the deaths that we see. So, but even hospital activity now in Wales and the rest of the UK is starting to come down. So we're not out of the woods yet. It can still come back to bite us. The schools have just gone back, and there will be another wave of transmission that comes as a consequence of that, I'm pretty sure. But really, we're moving to a position now where in the spring months, I would hope that we're able to start thinking about living with COVID, and moving on to think about the next phase. And that requires us to think. David, you talk about restrictions. I've stopped talking about restrictions. We did put some more measures in place in Wales, but I always refer to them as protections, protections for people. I think that's a more positive way to think about it. So we do need to remove some of the protections that we've had in place. We need to think hard about our testing program. I think we probably need to think about refocusing some of that effort on places like hospitals, like our care homes, like the vulnerable settings, prisons, those closed settings where we know that the virus can spread like wildfire. We need to think carefully about our vaccination programs. I agree with you. Booster after booster after booster is not the way to go. We need to look at integrating our coronavirus vaccination program with our seasonal flu vaccination programs. I noticed in the sidebar there was questions about the speed of relaxation. There's a basic principle here. It's a public health principle, I think, which is that when you put measures, protections in place, put them in place quickly. If you want them to be effective, release them slowly as you come out of a wave. And that's certainly the approach we're trying to take here in Wales, really. The other thing we need to use the spring months to do is to review our health protection system and our arrangements for future waves. Because like you, I believe, we're not out of the woods. There will be other variants that come. Let's hope that they'll be mild ones. Let's hope we can live with them. Let's use the opportunity now to think about a couple of things. First of all, our surveillance. Obviously, WHO has a key role, I think, in global surveillance, but national systems need to look at surveillance systems as well. And we also need to look at how we work with citizens in terms of behavior, because I believe that, we're moving to a situation where people will know what they can do to protect themselves. People have learned those messages over time. Sometimes we don't have the systems in place, even in places like the UK, relatively rich countries, where people can deploy those things. So, we need to look at sickness absence and how we can provide insurance benefits to people so that they're able, when they have an infection, whether it's coronavirus or flu or the common cold, that they don't have to go out to work, they don't have to go and mix, and they can stay home and prevent further surges. So there's huge amounts to do, and I think we're in a slightly fortunate position in the UK. I'm really worried to hear what you say about because unvaccinated places or places that have had less opportunity to get their populations vaccinated are really at risk at the moment. And that question of global equity is one that really should concern us all, because we're not all, as we know, we're not out of it until we're all out of it. Thanks, David.
Frank, thank you. Where are you at the moment? In Cardiff or where?
I'm just near Cardiff, that's right. Yeah.
Very good. Good to see you again, and you're looking well. I was thinking, obviously, I've always enjoyed the way you look at things, and I was very interested that you got in your list, rethink about how we public health professionals work with citizens, and in particular, the really tricky question of sickness absence, which few of us have managed to get right. People will not stay at home if it costs them money, as far as I can work out. And I think you must have had a fair amount to deal with, a fair amount of that. Thank you for that. Frank, if you still stay, and if you feel like coming in again at any point, just don't hesitate, okay? I'm going to try and go around a bit and invite others to speak. Now, I wanted to do a little segment on long COVID. And I saw, Paul Garner, that you've been quoted at length by Tom Whipple. I think it was from the Times. I don't know whether you want to comment at all on what came out there and your own feelings. I'd like to go to Claire Rayner, if you feel like it. As always, you're here quite often, and it's lovely to hear from you. And anybody else who wants to spend a moment or two talking about long COVID, either from a personal perspective or from a professional dealing with the challenge of long COVID, which seems to be rising up in the ladder of issues that people are worried about. Paul, if I haven't checked with you, if you're okay, do you want to come in now?
Sure. I mean, in brief, long COVID was seen as something new, like the virus was new. And we got to a stage of understanding, is it the virus causing all these multiple problems in the tissues, or was it the immunology that was out and disordered? But actually, it isn't that new. And the Times pointed out Thomas Dow's in 1894, after the Spanish flu, which was probably a coronavirus, thousands of people had neurasthenia, which is indistinguishable if you read the descriptions from long COVID. And actually, if you read Hurry's book from 1915, The Vicious Cycles of Neurasthenia, that's the same. And if you talk to doctors that worked in or work in ME chronic fatigue clinics, they've seen a lot of these things before. It's just not the volume that is there at the moment. And this is all very important. The other thing that was important in Tom Whipple's article was that he made reference to the fact that it is probably some dysregulation in your autonomic nervous system in your brain that is causing this stress alarm across the body, and it becomes self-sustaining and it feeds itself. And I think that that's what happened to me. The symptoms are so severe and so real, but they feed back and keep your body in a primal state, an autonomic state of high alert, and that boosts your cardiovascular system and other things and causes these medical consequences. But it isn't the virus attacking the tissues. It relates to this, almost the thermostats in the brain that have gone awry. The control systems in the brain have gone awry. And that the reason why this part of the narrative is important, because previously you end up with what's the medicine and what's the test. But if you appreciate that it is a brain-body connection, then in the narrative there is approaches that can help you calm the stress response. Psychological approaches and also physical approaches can help you. And also, and this is controversial to the people that are getting better at the moment, your beliefs in what is going to happen to you strongly affect the values that you attribute to the symptoms that you are feeling. And if you start reassigning meaning to them, things become, so the fear factor in long COVID fuels the symptoms. So that's why it was important, David, because that is a narrative that I honestly believe is right. And the bottom-up groups of long COVID sufferers, some of them are benefiting from this. It doesn't exclude these medical complications that need managing. So that's why it was important, David.
Thank you. It does seem like, from the way it was described in the article, that there are quite a number of different syndromes that are coming under the collective name of long COVID. And that would make sense, especially given more and more information about the actual pathogenesis that occurs, understanding actually how that can be associated with factors that lead to increased clotting and so on. So, Paul, thank you for that, and thank you for being with us and for your leadership. I hope you don't mind if I just go on, and I'd like to go to Claire Rayner, if you're there. Any of your reflections over the last 2 weeks, please?
Sure. Yeah, I think that's right. As you've both said there, I think there are a number of different clinical situations or scenarios under that umbrella of long COVID. I think it's the impact that I'm probably particularly want to say something on this week. You asked me last time, what could we expect with Omicron? And I think, we're a few weeks into it. It's amazing. I thought it had been longer, but it's actually only just over a month, isn't it? The support groups tell me they're starting to see people come through with problems, but it's really too early. And as I said last time, I'm sure there are people that just take much longer time to get over this than some. My second group of people that I'm really worried about are those that have been first waivers with long COVID. And I think it's some of them where some of the clotting issues and so on are coming up. So I think there's some fairly crucial health problems that have to be sorted out for some people. And then the impact on work, as we've touched upon it with the sort of sickness pay thing. The numbers involved are huge. They're of working age, and I think it's that impact on, we're nearly 2 years down the line. And I know it takes it back a bit to the more acute stage, but I absolutely agree about if you're going to have people sticking to public health recommendations or requirements, if you have an infection, it's really important to get the pay issues right. I think I don't think there's anything more that's new. I think one of the things is problems with the health systems. I think GPs speak about they're just getting referrals to cardiology and neurology turned back, and these are the two common areas where people need things excluding. So I think that contributes to the length of time that people are waiting. If they could get some assessments earlier, if they could get some symptomatic treatments, start building up that function, I think we would have less prolonged sickness absence and less prolonged impact on the economy.
Thank you very much, Claire. We're going to have to be super rapid fire here. We've got so many issues that are right at top of mind, and won't always be able to have a long discussion. Always grateful to both Paul and Claire for joining and participating. I would like to invite I'd like to invite Joe Nichols, if you are able, to give us your dispatch from East Africa. I would like to ask Ndirmwa, if you've got decent internet connection, to give us your latest observations, and if you're in Nigeria, or tell us where you are. And then I would like to go to Scott Knox, if you're available. We've got a number of questions I'd like to invite you to respond to, and I'd like also, if we can, to get some comments from Autumn Lerner of the Pandemic Action Network. I'm hoping to come back to Catherine Deland before we close. Let's see how efficient we can be. Joe Nichols, please.
Thank you very much. Yeah, I mean, over Christmas and New Year in Kenya, the rate of positivity had gone up to about 30%. So I think there was a lot of concern. And at the moment, I think the ICU beds especially are still full, but the positivity rate's gone back down to about 6%. So I think there's a sense that things are slightly improving. There's still, relatively low vaccination rates overall. I think even in Kenya, it's about 15%, and in Somalia, it's significantly lower. And there's still that divide between the urban areas with higher rates and the rural areas with much lower rates. I mean, one thing that has come up recently is the challenges of using the mRNA vaccines, which meant if you want them to last for longer, then I understand they have to be stored at lower temperatures. But there's also been some discussion, which it would be really interesting to hear a bit about if you only need it to last for a very short while, then it doesn't have to be kept quite so cold. And I guess the other thing is still the appeal of the Johnson & Johnson vaccine, because it's still perceived as one shot. That's something kind of that seems to be interesting to many people. Thank you.
Thank you. I'm super impressed to hear that your positivity rates come down and that generally things are not so bad. One of the issues in Nairobi, at least, was reports of quite high seroprevalence. So it's certainly makes sense on the basis of what we know so far, that at least in the urban areas where there's been quite high levels of infection plus or minus immunisation, that things will be not too bad. What other colleagues were telling me was perhaps the thing to look at is what happens outside the cities, more in rural areas, and of course we don't necessarily know that. Thank you, Joe. Any last comment you want to say just about how Zara and Miles? Always keen to know how your family are.
Everyone's doing very well, and Miles is also listening. And you're absolutely right. I mean, we don't have very much sense at all of what's happening in rural areas, even in accessible bits of Kenya, let alone in places which are inaccessible because of insecurity and conflict in countries like Somalia. It's very hard to get data.
Thank you very much, Joe. Ndirmwa, can you hear me? Are you there? How's your internet? I can see you've unmuted. Can you hear me? Okay, it's not good. Best that you don't say anything. Just see if you can go to a place where you get... It's not good enough. No, not going to work. That's really, really frustrating. Sorry about that.
Evening.
No, very, very troublesome. Okay.
From here, from there.
It's not working. So let me go to Scott Knox, please. Scott.
Thank you, David. I just wanted to come back to the comments you were making about data, because data to me in my industry, representing the marketing, advertising, media and PR sector in Canada, the thing that I did want to caveat with the Edelman report, just for everybody's context, but also even reports published by organizations like YouGov and others, they rely on people being truly cognizant of themselves, in the sense that if you ask people, what do you trust? We all respond and what we think we should say, whereas actually how we behave can be absolutely counter. And the other thing is that when we look at do you or don't you trust politicians, actually you average out that data and it gives you a full sense of what you're telling. If you ask most Republicans, do you trust politicians? And then you name one, they will say absolutely. If you say the same to Democrats, they will say absolutely. But generally, do we trust politicians? It sort of starts to even out. So it's really important to understand these behavioral concepts behind these data gatherings. And the other thing is social media is a really interesting concept. We live in a world right now where data and what data means and who interprets data and what it says is becoming more and more complicated and more pulled in different directions to prove things that people want to prove, as opposed to what they actually tell us. We know that actually the majority of people will say we don't trust social media. And I think that's the concept of social media. However, if you ask people, do you trust WHO on social media and their platforms? People will say absolutely yes, or even certain politicians. So it's really important to take into consideration when you look at these, how do people behave pieces of data, and take out of it how we behave as human beings. But what I did want to ask, actually, and I put into the question.
Hey, hang on, Scott. Does that mean?
Sorry.
Do you have a fundamental concern then about the things like this trust barometer? For me, the reason why I take it seriously is they use a relatively similar methodology each year. So
yes.
Even though there are imperfections, if you get a shift, it may well have some meaning.
Absolutely.
All your caveats accepted. Over.
Yeah, no, I completely agree. There are times where you can take a piece of research like that, which is used hugely across the whole of the marketing industry, not only in terms of brand activation, but also what governments and NGOs do in spending their money. But you have to understand that actually what we say to somebody interviewing us and what we say actually can be counter to what we actually do. And so it's important to see those two in context with each other. Right. And I say that actually particularly because we've got people like your colleague, the CMO from Wales. Yeah. I see the fact that we know social media is believed to not work, but the amount of money being spent by organizations and governments into social media about COVID is huge. Yeah. But yet we know people don't trust it. Whereas we know, actually from a marketing perspective, the most trusted source of information is print news. But the expenditure into spending for getting messaging out in newspapers is at an all-time low. Yeah. So that whole trust balancing act needs people to really understand what they're interpreting in order to make it effective, particularly when communicating about COVID.
I hope, Scott, you'll communicate with us through Sidebar, and that we can get a session where you talk about this at greater length. There's something really, really important to me in what you've just said. And although I think I realised it, perhaps it was sort of hidden somewhere, you brought it right up to the top. And it's very, very helpful. Thank you, Scott, as always.
No problem.
I hope I didn't interrupt you. If I did, excuse me. I'd like to go to Autumn Lerner. Autumn, you are working in a really important initiative on getting really equity on access to vaccine, Pandemic Action Network. Give us 1 minute on the thing you most want this group of amazing people to hear.
Yeah, thanks, David, and thanks, everyone. Yeah, the network was created as an advocacy network to ensure that ending the COVID crisis stays as a top political priority and that we actually learn the lessons of this crisis so we're better prepared for future pandemics. I think the thing that's top of mind for us right now is narrative and messaging. Communications is critically important. The story that we tell is critically important to ensure that we actually do end this crisis. And as we look ahead to the third year of this pandemic, the lifting to make sure that political leaders and leaders overall take this seriously becomes even harder. There's this counter narrative right now, and we're seeing it across the board this week, in fact, a lot of like, oh, Omicron is basically the end of the pandemic. The pandemic is over. Meanwhile, we know that that is not true when we have a huge proportion of the world that haven't even received a first dose, let alone being fully vaccinated. And Omicron has moved the goalposts on what it means to be fully vaccinated. And so the story that we tell really does matter, but we're not winning on that stroke at this point. The vaccine equity message is not working or landing. No one is safe until everyone is safe is not working or landing. And so we're really working as a network to look at how we shift the political calculus and shift the narrative to re-inject some urgency, some rage, and really light the fire under world leaders to act. Because, you know, just this week we had the head of Gavi come out and say, like, there's no money in the coffers, and that is what we need to really get from just talking about vaccine doses to actually, you know, jabs in arms at the level that's required to make a dent in ending this crisis.
Thank you very much indeed. Thank you to all the work that you're doing. And I'm not giving up, and nor are you, but we probably need to have another session with the leader, with you all, and with the WHO leadership, just to think again tactically about whether any adjustment is necessary. Thank you again. Very good. Andre Hoffman, I love it when you're here. I've worked with you on and off for quite a long time now. And if I can persuade you to give any comments on what you're hearing, that would please me. If you'd rather be silent, I understand.
Well, David, of course, how could I refuse the privilege of talking? As I said in our exchange on small messages, I always learn a lot when I come and listen to these briefings. And I must say that if there is one thing that dominates, it's this notion of Omicron being the solution, not. And you know, this incredible fatigue of people around me. You're talking about underreporting. Well, you know, we should use a huge multiple on this. People around me are testing positive at home, but they're not telling anybody, and they don't appear on the statistics. And that's you know, that's something which creates a behavior which amplifies the problem. And you know, when we come to this trust, I'm really not a public health professional. I happen to be involved in healthcare for a family company. And so people come to me and ask me, Andre, what is going on? And the sort of story I hear are just extraordinary. I mean, we haven't been very good at talking about very simple, basic science. Most of the things we learned at school are long forgotten. And there is this anxiogenous activities, which consists to get more and more involved into all this. So the idea that long COVID is self-inflicted in a way, you know, difficult to explain. But I thank you very much for what you're doing, David. I think it's extremely important to talk sense about all this and to bring us back to realities. You know, we must realize that what we have done in the past wasn't up to it, and we must use this opportunity to write better systems. Let us be better at collecting data. Let us be better at warning ahead of the curve. And I'm sure that the opportunity to converge all this understanding and experience into something more practical will be seized. So thank you, David.
Thank you, Andre. And I mean, like you, I feel this incredible sense that things that we've learnt over the years are somehow being ignored, disregarded, or just simply forgotten about. And yet, given that we are 3 years into a pandemic, never was it more important than now to be able to apply our learnings. John Atkinson, who is regularly with us and who I see has managed to organise to come out of a car park and I think you're at home in Rugby, John. John Atkinson is a specialist in systems leadership, and you've been looking at this really non-stop since it all started as a systems challenge. You heard Frank Atherton refer to the systems that have got to be stitched back together again. What's your take on where we are right now, John? Over to you.
I think when we talk about systems, it's too easy to think of them as abstract things, you know, testing systems or diagnostic systems or treatment systems. But actually, our systems we're talking about are full of people. It's people and how they connect and how they relate to each other. And I was particularly, you know, my take at the moment, David, is your summary at the end of your intro about humility, about wholeness. These are lessons that we can all take. It's easy to project leadership onto other people. Our politicians may be seen to be failing us, but I've seen some really good examples this week of people in, you know, vice chancellors of universities, people in business, saying, "Look, I feel I have a responsibility for the environment in which my people come together, do their work, do their socializing, whatever it might be, and I'm going to still take responsibility for making sure that I do the things that I understand to be best, regardless of anything else that's going on. So I'm going to still encourage people to wear masks when they're close together. I'm going to still encourage people to isolate if they're getting unwell, and I'm going to make sure that when they do, I look after them." And if we take that attitude to each other, the idea that people are the solution, I think, gets underlined. So that's where I am with it, David. We can all, to pick up on your 5 H's.
Thank you, John. The 5 H's were, just in case it's helpful, whole of humanity, not just a subset, number 1. Number 2, think of the whole person being holistic. Number 3, maintain genuine humility. Number 4, be honest. Absolutely don't stretch the science. And number 5, hopefulness when it is justified is really helpful. Okay, so that was my go to try to find a way to share what I thought about the challenges of communication, mostly because this week I've found it so difficult. I've often told you that I find my positioning, particularly on media like television channels and so on, I find it hard, but it's got really hard this week. Thank you, John. Catherine, for last word, and then we go to Chris, and then we'll say goodbye. But Catherine, I want to give you just a chance to say your bit.
Just to say thanks to everybody for being here. I think there's a couple of really important things to remember. Omicron spreads exactly the way every other COVID variant spreads. We know how to keep the transmission down. So stay safe, wash your hands, wear your masks, stay socially distanced. And the more that you demonstrate that your actions prevent it, the more other people will follow. This is how social movements start. Thanks for spending your Friday evening, for those of you who are in this part of the world with us, and your morning or your late night, wherever else you are. Stay warm if you're in the north, stay cool if you're in the south. And Chris, do you want to bring up your illustration for a moment?
Yeah, I think today's theme has been leadership, hasn't it? By the looks of things.
Yes, I would agree.
And I do think, just on, you know, narratives, it's very interesting that I think the world has changed. We're not going back. And that's an extraordinarily difficult narrative for any political leader to adopt, but it's not impossible. Also, I was really glad to tune in today because that information on the brain and flight and fright, I've drawn my brain in a jar, but I haven't done for ages, meant a lot to me personally, because my December was rotten, and I mentioned it in the chat. It made a tremendous amount of sense to me. And one other thing, you know, David, everyone in our little group at Live Illustration, we stop everything if we hear you on the radio and pay fierce attention. So, you know, please carry on. We enjoy your performances.
Thank you. That was unsolicited and beautiful. Great. I've sent you a tiny direct message in the chat. You'll understand why I've sent it to you. And everybody...
Whoops.
Now you understand. There are lots and lots of people who we've been connected to. We've got a really good reunion session today. There are people who come back who've been away for a bit. It's lovely to see Nigel Lloyd of Camprof here. Lovely to see Ad Spikers here. Lovely to see Anne von Bolhuis here. And Iman, of course, Christina Pavlescu, and really, really good. I'd like to go to everyone and give you all a big hug. It's not possible. We have to stop now. I'd like to say goodbye. Please stay in touch with us. Use the LinkedIn group. I just wanted to say Mahika Acharya is now the person who's looking after things, but down on the bottom of my screen is somebody with the name Tui Marien, Thuymaryen. Tui Marien is actually Tui changed her name. Here is our Tui, and our Tui and her Lara here. I don't know whether her Lara's in the picture, but anyway, nice to see you, Tui. Thank you for joining. And Mahika, if you'd just like to wave, and if you want to just say a couple of words, just to make sure that everybody knows who you are, because Mahika has picked up the reins where Tui has left off.
Big shoes to follow, but I'm glad to be here and very happy to meet everybody.
And just next to Tui to Mahika on my screen is Peter Hebard, who is just doing a most amazing job on trying to help everybody understand that there's no point in wearing a mask if it doesn't do the job. And he is extremely keen on that. Peter, you can have the last word.
Right. Just remember, a good mask is a lockdown on your nose. And if you've got to go to work, wear it, and then you won't infect anybody. That's all I have to say. But thanks, David. You're right on. Absolutely spot on what you said. Well, cheers, Peter, everybody.
Peter, just keep up this work, because honestly, a good mask makes an awful lot of difference. Thanks, everybody. Bye-bye. Have a very good weekend. See you all in 2 weeks' time. Bye-bye.